Hello, I would like to welcome everyone to the IBM Watson Health Executive Webinar Series. Today's presentation is titled Navigating the Merit-Based Incentive Payment System, presented by Dr. Maria Valderas, Clinical Informatics Analyst at IBM Watson Health. Before we begin, I would like to review a few housekeeping items. First, you have a control panel on the right side of your screen. You can minimize and expand this panel by clicking on the arrow in the upper right corner. Second, you can submit questions using the question panel located near the bottom of your screen. We will try as many questions as we can at the end of the presentation. If answered, we will respond to you individually after the event. Finally, all registrants will receive a copy of the presentation and a link to the recording within 48 hours after the webinar. The information will be sent to the email in which you registered for this presentation. Next, I would like to introduce Dr. Maria Valderas. Dr. Valderas earned her PhD in Public Affairs with a concentration in health policy and has over 12 years of experience working in the healthcare industry. Most recently, she spent several years working for the U.S. Department of Health and Human Services, Office of Inspector General, where she both led and contributed to several national studies and had the opportunity to make recommendations to several HHS operating divisions, and as well as respond to congressional requests. Dr. Valderas joined IBM Watson Health as a clinical informatics analyst. Today, Maria will explain how the impact of the merit-based incentive payment system could be affecting you. Maria, the floor is yours.
Thank you so much, Sean. So before I get started, I'd just like to start with a couple of polling questions. I just basically want to gauge where everyone who's listening into the webinar is in terms of both tracking and reporting into the merit-based incentive program system. So what I'll do is Sean will open up the polls, and if you could just respond to a couple of questions, and I really appreciate it. So Sean, could you open up the poll?
Everyone should be able to provide their response.
Okay, so just take a few seconds and quickly respond. That would be great. And Sean, I'm not sure if you could, at what point, you can just go ahead and see who all responded.
Yep, I can show results now.
Okay, great. Okay, I'm not sure if I need to be seeing something. So as you can see, the first question is basically trying to see if you or your organization is planning to use a vendor to help track your merit-based incentive payment system measurement performance. So if you're needing somebody or a vendor, you're going to be contracting with someone to get that information or to track it. If you could just respond, definitely, possibly, probably not, I don't know, or if not applicable, then submit not applicable.
And we can go to the next polling question.
Okay, great. Okay, so the next polling question is similar to the first one. However, this one is, are you or your organization planning to use a vendor to help report your MIPS data to CMS? So not tracking, but being able to format it, being able to submit it through various ways of submitting data into CMS. If you're planning to use a vendor, if you could please respond either you're definitely going to do that, you're possibly going to do that, you're probably not, you don't know right now, or it's not applicable. And whenever you're ready with those responses, that would be great too, Sean.
Sorry, Maria, I'm not sure why it's not showing the results, but we have 34%.
Okay. Hey, not a problem. Not a problem. I'm sure we'll be able to gather that. It's just technical difficulties. If okay with you, Sean, can we just go ahead and move on then?
The floor is yours.
Great. So I appreciate everyone's response. Hopefully, for those that fell between the probably not and that you don't know in terms of whether or not you'll be tracking this information or even reporting it to CMS, I hope that today's presentation provides you additional information about the merit-based incentive payment system. And so just today, I'll just provide an overview about the MIPS program, which is one of CMS's quality payment program paths, brought by the Medicare and Access Chip Reauthorization Act of 2015, also known as MACRA. But before I get started today, I'd like to introduce Dr. Bill Kassler. Now, Dr. Bill Kassler was formerly Chief Medical Officer for New England Region at CMS. Dr. Kassler also spent many years working in CMS Innovation Center, developing and testing new models of paying for population health. Dr. Kassler joined IBM Watson Health as a Deputy Chief Health Officer and a Lead Population Health Officer. And I'm excited to have Dr. Kassler open up the presentation with a few remarks. Dr. Kassler?
Hello, and it is my pleasure to welcome you to this webinar. I'll just take a couple of minutes and provide a broad policy context for what Maria will talk about. We all know that the current health system faces serious challenges. Healthcare is too expensive. Our payment system incentivizes volume over value. And our health delivery system is quite fragmented, resulting in waste and a level of quality and patient safety that has serious room for improvement. A major policy lever to address those challenges is value-based purchasing, which involves using financial incentives to drive provider and delivery system behavior towards improvements in care. It's an approach that is currently favored by many national experts at the federal level. Fee-for-service payment is based on resource consumption, not outcomes, and provides neither incentive nor support to improve quality of care. Historically, in a fee-for-service environment, Medicare reimburses for services as long as claims are submitted appropriately according to administrative and policy regulations, regardless of the quality of those services, regardless of whether those services were appropriate to the patient or whether they led to improved outcomes. So in response, for a number of years, CMS has been seeking to change that, to transition Medicare from a payer of claims to a purchaser of services. And policymakers in Congress and CMS have been grappling with how best to design and implement value-based purchasing programs so that they're successful in achieving those goals. The Medicare program has been gradually moving towards implementing value-based purchasing across many care settings, starting in the hospitals and more recently rolling those out for clinicians in group practices and then at the individual practice level. CMS started those programs very, very tentatively about a decade ago with its pay-for-reporting program for clinicians, PQRS, the Physician Quality Reporting System. Later adding the e-prescribing and electronic health records incentive program, also known as Meaningful Use. Then in 2010, the Affordable Care Act significantly expanded those activities by requiring CMS to adjust all fee-for-service payment rates with a value modifier based on cost and quality. The ACA also authorized and funded CMS's Innovation Center to develop and test alternative payment models, such as ACOs, medical homes, and bundled payments. So now comes MACRA in 2015, which required CMS to accelerate those changes and combining many of their previous patchwork of standalone programs that were poorly aligned with oftentimes competing information systems and deadlines into a single system, which they now call the Quality Payment Program. That system, in turn, has two paths. The merit-based incentive payment system, MIPS, which is based on fee-for-service, and an alternative payment model track, which are based on some of those new models emerging from the Innovation Center. So this webinar will focus on the MIPS program, and I'm going to hand it back to Maria for the rest of the presentation. Thank you for attending.
Thank you so much, Dr. Kassler. I appreciate it. I'd also like to acknowledge IBM Watson Health's commitment to the quadruple aim of improving quality of care, reduce costs, improve experience and engagement by patients and providers and their care teams. We would welcome the opportunity to become your IT partner, especially as healthcare moves towards value and quality-based care. So as Dr. Kassler mentioned, MACRA changes how doctors get paid, and it takes a big step forward for health care quality. Now, the proposed rule details CMS's implementation plan for administering MACRA's new payment system, so the MIPS and the Advanced Alternative Payment Models. Now, MACRA replaces measurement programs like Dr. Kessler had mentioned, the PQRS, the Value-Based Payment Modifier, and Meaningful Use. And it replaces it with a single framework that can provide the basis for a more flexible, relevant, and ultimately a simpler-to-use system. Now, according to CMS, the program brings changes intended to promote coordinated care at a reasonable cost through a uniform merit-based system. It is defined in the statute to focus on quality, both standard measures of care and practice-based initiatives of the physician's choosing, and encourages the use of technology. Now, physicians and other clinicians who do wish to go further will receive additional bonuses and will be able to join more advanced approaches to care for patients like medical homes, specialty models, and team-based models that improve quality and manage costs. So by using a unified framework called the Quality Payment Program, and many of you might think of MACRA, but think of Quality Payment Program now, CMS implemented the changes outlined within MACRA. Now, prior to MACRA, costs regularly exceeded the predicted targets, and since 2002, Congress has regularly passed temporary so-called doc fixes to avert these cuts. Now, the fix meant that the deficit or cut would roll over to the next year, basically compounding the problem. For example, had there not been a doc fix in 2015, clinicians would have experienced a 21% payment cut across the board. So instead of relying on these last-minute doc fixes, MACRA replaced the Sustainable Growth Formula, which many of you probably already know. It was linked to Medicare annual payment adjustments for physician services to GDP growth. And it replaced it with a more predictable payment method that promotes value in the long term. First, the way that clinicians are paid will change, right? So this is what MACRA is doing. And this slide illustrates the way that our current system works. So as you can see, a clinician provides certain medical services. The Medicare fee service then determines how much the clinician gets paid per service. And then on top of that, there are currently several reporting programs, as already mentioned, that provide bonuses or penalties to providers at the end of the year based on the relative performance. After adjustments, then clinicians receive their final payment. However, under the MIPS program, this will replace those programs and provide one single adjustment. Now, clinicians may also have the opportunity to earn special lump sum bonuses through participation in eligible APNs and be exempt from MIPS. Now, as mentioned previously, Medicare currently has a number of different quality programs right now, and all of that will be streamlined into that single program that is known as Merit-Based Incentive Payment System, or MIPS. Now I would like to just further discuss the MIPS program, or the Merit-Based Incentive Payment System. So in order to implement changes outlined within MACRA legislation, CMS used this unified framework called the Quality Payment Program, which establishes an alternative set of predictive annual baseline payment updates. And as such, the framework includes the two paths, as you can see, the Merit-Based Incentive Payment path, which will be discussed further today, and the Advanced Alternative Payment Model, which we plan to cover at a later date in another webinar, but I'll briefly touch on that. Now, under the Quality Payment Program, CMS outlines 4 strategic goals that I'd like to just briefly talk about quickly. The first one is design a patient-centered approach leading to better, smarter, and healthier care. Second, develop a program that is meaningful, understandable, and flexible for clinicians. Third, design an incentive that drives delivery system reforms principles and participation in alternative payment models. And lastly, to ensure attention to excellence in implementation, effective communication, and operational feasibility. As I mentioned, the Quality Payment Program repealed the SGR formula. It shifts focus from volume to value. It streamlined multiple quality programs, and it provides bonus payments for participation in eligible alternative payment models. Now, before moving on, I'd like to emphasize that only Medicare Part B fee-for-service payments will be affected. So again, that's Medicare Part B. So basically, it's your doctor visits, those services, preventative care, etc. So just keep that in mind as we move forward in this presentation. Now, under the MIPS proposed rule, so anything moving forward, everything is based on the proposed rule, which will be finalized November 1st of this year. So there's a possibility there might be changes, but as we go through this slide, just know that all this is based on the proposed rule. Now, under this MIPS proposed rule, there are several major provisions. One, it outlines who is eligible to participate. Two, it details each type of performance and how scoring will be weighed in each category. Third, it provides several options for submitting data to CMS. And lastly, it provides performance period payment adjustments. Now, according to CMS, the majority of eligible clinicians will participate under the MIPS program the first year. So as you can see on your left-hand side, these are clinicians that will be subject to MIPS, and these are basically, if you're not part of an alternative payment model, an APM, like an ACO, for instance, you will be subject to MIPS. If you are part of an alternative payment model but are not one that is selected by CMS to be determined as advanced alternative payment model, and those, just to kind of share with you, those are your shared savings ACOs, specifically your tracks 2 and 3, the next generation ACO, comprehensive ESRD care, CPC Plus, and oncology care models. Now, this will be changing, and there's a task force out there to determine what advanced alternative payment model should be included for the following years. These are the ones that are proposed. But if you are not part of any of those advanced, you will be subject to MIPS. And lastly, if you are a part of an advanced APM, but you don't meet those thresholds in terms of risk and revenue, so you do belong to one of those groups that I've mentioned, but you don't have that you don't need that extra criteria to be part of that. You will be considered a partially qualified participant. So you're not eligible for that bonus payment under the advanced APM. However, the advantage of being a partially qualified participant is that you can decide to participate in MIPS. Now, while all clinicians who belong to an APM, whether advanced or not advanced, will still be required to participate in MIPS. In order to determine whether clinicians meet the requirements for the advanced APM track, all clinicians, and again, all clinicians, will report through MIPS in their first year. Now, according to the proposed rule, there are special scoring and data submission rules for clinicians that participate in alternative payment models, but are subject to the same reporting categories under MIPS. However, these APM clinicians will have varying requirements and performance weights based on the type of APM that they belong to. Now, in order to be classified as a fully qualified participant, so if you can see on that right side, it is required that the clinician meet increasing thresholds for the percentage of their revenue they receive through qualifying APMs. Now, so basically, those that are qualified APM participants will be exempt from MIPS. And basically, they meet that higher threshold compared to a partially qualified participant, and they're eligible to receive that 5% bonus payment beginning 2019. Now, basically, no matter which side you fall on in this picture, the Quality Payment Program provides multiple ways for clinicians to be rewarded for responsible practice and provide multiple incentives to participate in APM. Now, having said all that, who does MIPS apply to, right? Well, as you can see, you might hear terms such as eligible provider, eligible clinician, eligible professional. Well, they're all one and the same. So individuals that are included in years 1 and 2, as you can see, are your physicians and your mid-level providers, so your physician assistants, nurse practitioners, and let's not forget your dentists. You know, they're specialists, and that they're also part of, if they're receiving Medicare Part B services, not services, but payments, they will also be subject to this MIPS. Basically, those that are subject under years 1 and 2, as you can see. Now, on the right-hand side, you'll see more clinicians there. You'll note something I'd like to note is that there's flexibility in the legislation to expand and include other types of MIPS eligible clinicians after the first 2 years of the program. So in years 3 and beyond, the Secretary may broaden eligible clinician groups to include other subjects, others such as therapists, nurse, midwives, psychologists. And I will emphasize, they may broaden. So just an FYI, that may change. It may include more or less. It just depends. However, this is yet to be determined. Now, having noted this, CMS does encourage clinicians that are not required to report in years 1 and 2 to voluntarily report in order to gain experience reporting under MIPS. However, they will not be subject to that positive or negative fee adjustments. Instead, they will get that experience. Having noticed that, there are some exceptions to the MIPS adjustments. So as you can see, there are 3 ways that you can be exempt. So there's 3 groups. The first one is it'll be your first year, so since it's predicted in 2017, that's when reporting starts. If you are a physician or a clinician under that years 1 and 2, under that list that I mentioned, it's your first time reporting under Medicare Part B participation, you will not be subject to MIPS. The second one, if you have very low threshold of volume of patients that you see, so less than or equal to 100 Medicare patients, or you receive less than or equal to $10,000 in Medicare fees, reimbursement. And the last one would be certain participants in eligible alternative payment models. Now, in addition to these 3 groups, it's very important to clarify that MIPS does not apply to hospitals or facilities. And when I say facilities, we are talking about your skilled nursing facilities and your long-term care hospitals, for instance. It applies to individual clinicians. Now, MIPS reporting on the 4 performance categories can be achieved at the individual level or at the group level clinician using a group tax identification number, or your TIN. And so I will say that CMS understands individual and small practices will face quite a bit of challenges transitioning to MIPS. And as such, the law provides that solo and small practices may join virtual groups, as I note there, and in order to efforts to become a group. However, CMS is still trying to hash out the details in terms of virtual groups in order to construct the anticipation of what it all will entail in terms of virtual groups. So this program is anticipated to start in 2018. So just note that. And really, basically, CMS just wants to make sure virtual groups technology is meaningful and simple to use for physicians, which is why they're weighing in everyone's comments in terms of these virtual groups. But they are very much aware of the challenges that are faced by solo and small practices. Now here, this is the MIPS performance period. As you well know, it will start January 1st, 2017 in terms of reporting, and this will affect your adjustments in 2019. So do know that 2017 reporting will determine your adjustments on 2019. Now, in terms of submitting data, I know many of you are probably wondering what's the deadline in terms of submitting data. Well, the submission deadlines would apply for qualified registries, your QSDRs, your EHR, the attestation submission mechanisms. Those would have a deadline. Right now, it's noted you can start reporting your 2017 data starting January 2nd of 2018, and that would run to March 31st of 2018. However, if you're using the web-based, CMS web-based interface submission, they're proposing a deadline that would occur during an 8-year period following the close of the performing period, which will begin no later than January 1st and end no later than March 31st. Now, as you can see, CMS will receive this reporting. They will analyze the reported information and will then determine the performance threshold that will be used to determine that positive, the neutral, or negative fee adjustments that will occur for 2019. Now, I will note that according to a recent Senate Finance Committee hearing that took place last month, Acting CMS Administrator Andy Slavitt mentioned that CMS understands clinicians' concern with the start date of January 1st. So CMS is very much aware of this, and as such, he said that CMS is evaluating and even considering such options as different start dates, shorter reporting periods and such. And he also mentioned that they're open to all ideas like minimizing reporting and even automating some aspects of the reporting needs for providers. However, this is still yet to be determined, and we at IBM Watson Health continue to monitor these developments closely. Now I'll transition into the MIPS performance category and scoring. So what will make up the MIPS composite score, performance score anyway, right? So performance categories will be weighed, as you can see, on a 0 to 100 scale. It will contribute to a composite performance score in 4 weighted categories, and which are quality, resource use, clinical practice, improvement activities, advanced care information. And the score will be compared to a performance threshold that CMS will calculate based on available data from the 2017 reporting period. The scores from 2017 will determine payment adjustments in 2019. Now, most of these categories should not be new for some clinicians that are already reporting to some of these programs like PQRS. Here you can see each category has a percentage weight that will change over time. And again, all these weights, you can see that the quality category will take over the majority, so half of that will be based on that quality category, will take most of your composite score, will comprise your composite score. So just keep that in mind. Here, I won't go over this slide, however, I just wanted to include it for informational purposes since it does provide fairly useful information like the points, maximum possible points. It provides just useful information. And this is all based for the 2017 year, and this will change as years progress. So before I move on to talk about each category briefly, it is important to note that CMS has made efforts to retire existing measures that do not add value for clinicians or patients. And for example, measures that are topped out, in other words, those that allow little room for improvement because most clinicians already perform highly in those particular measures. They're also retiring weekly correlated with health outcome, and also those that are no longer clinically relevant due to new advances in medical treatment. And I will mention that CMS did, in comprising all these measures that are outlined in the regular, they did work closely with those federal and state entities as well as private payers to create a set of measures that are aligned with a lot of entities in order to help reduce the burden on clinicians. So keep that in mind as we just go on to explain, as I move on to explain the 4 categories. Now let's look at the first quality performance category. As you know, the quality category encompasses the largest of the 4. This category replaces the PQRS reporting program. Now, unlike the PQRS program, this MIPS quality category, the number of reported measures is reduced from 9 to 6, and there's no requirement to report on multiple quality strategy domains. I will caveat that although they mention that CMS does encourage and recommend that you do maintain those strategy domains. Now, there will be more than 200 measures to pick from, and more than 80% of the quality measures proposed are tailored specifically to specialists. Clinicians may also choose to report a specialty measure set. So, and these specifically are designed around certain conditions and specialty types. Now, for patient-facing clinicians, you'll see that you'll have to report on one cross-cutting measure and an outcome measure. And in an absence of any applicable outcome measure, a high-priority measure may be substituted. Basically, these high-priority measures will focus on that patient experience, patient safety, efficiency, care coordination, and appropriate use criteria. And the threshold will vary between 80 to 90% of all patients, not just for Medicare patients. So according to the chosen reporting mechanism, that will determine the number of patients in that percentage range. Now, I will note that population measures will be calculated automatically through claims data. However, clinicians that are individual solo practitioners or small practices of 2 to 9 clinicians, they will only have 2 population measures that will automatically be calculated by CMS, whereas if you have a group of 10 or more clinicians, you'll have 3 population measures automatically calculated by CMS. Now I'll move on to the resource use category. Now the resource use category, basically the intent for this category is for clinicians to compare resources used to treat similar care episodes in clinical condition groups across practices and requires no separate data submission, so you don't have to do anything. It will be done automatically by CMS. And basically they'll be using claims data, and they will include per capita cost and Medicare spending per beneficiary measure. And for this category, clinicians that deliver more efficient, high-quality care basically will achieve better performance and results. And as you can see, this will be replacing the value modifier by adding 40+ episode-specific measures to address specialties, and the performance evaluation will be at the individual clinician level. One thing to take away from this, though, is in the event that a clinician does not have enough patient volume for any cost measures, because right now they have a minimum of 20 patients for each cost measure. So if you clinician or practice that for each one of those cost categories you don't meet that patient volume, CMS will reweigh this category to 0. However, they will adjust the other MIPS performance category scores to make up the difference in the MIPS score. So please do keep that in mind. CMS understands there's limitations to some of these categories. Now I'll move on to the clinical practice improvement activities category. And basically, this category is new, and it accounts for 15% of the MIPS score in the first year. For this category, MIPS would reward clinical practice improvement activities such as activities focused on care coordination, beneficiary engagement, and patient safety. And clinicians will be able to select from more than 90 options on 9 categories, all of which will be updated annually. So in addition to this, clinicians will receive credit towards scores in this category by participating in alternative payment models and patient medical center homes. In fact, if you are reporting to PCMH, you will automatically earn the highest possible points in this category, while those that are participating in alternative payment models will automatically satisfy 50% of this category, which is huge. So the more activities achieved and reported will only increase the score for this category. Now, one piece of importance here is if you are a non-patient facing clinician, you will only be required to report on one activity. So keep that in mind. And I will mention that IBM Watson Health currently supports PCMH providers, so keep that in mind. I'll move on to our last category. The last category is the advanced care information category. And this category is formally the Meaningful Use Program. And this category accounts for 25% of the MIPS score in the first year. And accordingly, a full year of reporting is required for this category based on the proposed rule right now. So just keep that in mind. But unlike the Meaningful Use category, this category is much more flexible. In fact, eligible clinicians can report as a group. So for this category, clinicians must use certified EHR technology and would choose to report a customizable set of measures that reflect how they use EHR technology in their day-to-day practice, with a particular emphasis on interoperability and information exchange. Now, this category will no longer require that all-or-nothing EHR measurement or quality reporting. This measure aligns with the Office of the National Coordinator for Health Information Technology. Now, according to CMS, they expect this performance weight of this category will be significantly reduced over time, particularly as practices and clinicians adopt more EHR technology. Now, as part, I will expand on this, and I do apologize, I should have moved that slide. I will expand on this advanced care information category by saying that this category is comprised of a base score, performance score, and a bonus score. As you can see, there's based on your base score will have 6 objectives that you can select measures from. And then also your performance score will be based on those 3 objectives, as you can see at the bottom of that slide. And the bonus point, I will elaborate on that one. That one's based on immunization registry reporting is required to be able to get that bonus point. In addition, clinicians may also choose to report on more than one public health registry and will receive 1 traditional point for reporting beyond the immunization category. Let's see. So basically, one thing to note, to take away on this particular category as well, in the event that none of these objectives are applicable to you or your practice, CMS does propose to reweigh this performance category to 0 and adjust the other MIPS performance category scores to make up MIPS score. So keep that in mind. Again, this is just for informational purposes. I just thought I'd provide this slide because it has a wealth of information, and I know that Sean will be forwarding everyone this presentation a couple of days after today. So I'd like to, I know that we have about 15 minutes or so. I'd like to dive into this MIPS incentive payment formula. So now, as you can see, payment adjustments under the MIPS program will be positively, neutral, or negatively based on a composite performance score for each clinician. As you can see in 2019, the maximum adjustment percentage will be plus -4%, and it will increase each year from there. It is important to, having said that, it is important to emphasize that these numbers are the extremes, and a clinician's particular adjustment can fall anywhere within that range. And it's also important to remember that the quality payment program is designed to be budget neutral. So this basically means that the total upward and downward adjustments will balance each other out so that the average change will be 0%. Now, to keep this program budget neutral, the law allows for scaling of the positive adjustment factor up to 3 times. So this means that the numbers in the green shaded area are not fixed, and that the positive adjustment reward could potentially be 3 times the percentage listed here. So as you can see, if you take 2019, you have 4%. If you multiply that by 3, that will get you up to the 12% range. Now, this scaling process will only apply to the positive adjustments, not the negative ones. So keep that in mind. Each composite score will be compared to a performance threshold that consists of the mean or median of the composite performance scores for all MIPS eligible professionals during a period prior to the performance period. Eligible professionals, clinicians whose composite scores fall above the threshold will receive a positive payment adjustment. Those whose scores fall below the threshold will receive that negative payment adjustment. The threshold, keep in mind that the threshold will reset each year, so physicians' composite score in 1 year does not affect their composite score next year. Now, on the positive side, CMS does propose that this, they will give credit for those who improve from 1 year to the next, as well as for achievement. So, you know, it's a learning curve, and they want to know that they, CMS wants clinicians and practices to know that they totally understand that this is, that they're in it with you and want you to make improvements. That will fall back to the patient's care, so keep that in mind. Now, I will say that once the performance thresholds are determined, all eligible clinicians above the performance threshold will be eligible to receive positive payment adjustments. There is no requirement that a certain number of clinicians receive negative adjustments, though. If the data is however, I will say that if the data is not submitted, so if you are a clinician or practice that decides not to submit, the law still requires CMS to give you a 0 performance and a negative adjustment will occur. So I'd like to move to an example. I've said quite a bit. So here, let's say that everybody has reported 2017 data into CMS. CMS has analyzed, and they came up they came out with a performance threshold of 60. They calculated a composite performance score threshold of 60. Then, as you can see, that 60. So you see that 60, right? And so if you score 25% below that 60 mark, which would be basically if you scored 60 minus 15, and so whatever that score is below, you will automatically get that maximum -4 payment adjustment. So keep that in mind in terms of the performance threshold. If you are at that 60 mark, and say 25% of that 60 mark, so say if you are at 75, you get a score of 75 or above, you will go into the running for that exceptional performance amount. And not only will you receive that bonus, so say in this case it would be that 4% bonus, you will also be able to receive that extra bonus for exceptional performance, which is outside of whatever comes in terms of those that were in the negative. So this is additional money that CMS has allocated for that exceptional incentive. Okay, so say you decide that, you know what, I'm just going to forego and I am not going to report to MIPS in 2017. Okay, well, let's go ahead and take an example. So say you're an underdog in the world of MIPS, you know, say you're a nephrologist, right? So when talking to fellow nephrologists about this and proposed rule, here's a few responses. They say, why bother? I'll just take the penalty, right? Well, at first, that doesn't sound too bad, right? So let's assume you're a solo nephrologist. You bring in about $250,000 in Medicare Part B business. Not participating in MIPS would result in a loss of $10,000 in 2019. Okay, well, you can deal with that, right? Well, let's quickly move on to 2022. That has now shifted from $10,000 to $22,500 and beyond. So putting that in terms, that could be an FTE that you can have in your practice, or even for just to be able to invest back in your practice. Now let's multiply that by how many clinicians make up your practice, and it adds up very fast. Basically, CMS, just keeping in mind the nephrologist example, CMS estimates 42 of nephrologists will face payment penalties in 2019. But on the flip side of that, they estimate that 59% of these nephrologists will receive some of the $37 million of incentive payment. So keep that in mind. Now, say you don't report, right? You get that penalty. There is something I'd like to emphasize. Now, while you decide to handle your monetary, you decide to get a monetary hit on this, what if your name and quality results were publicly posted and compared to your peers? By law, let's not forget that CMS will make public the results of the quality payment program on the Physician Compare website. So the hope of that Physician Compare website is to help patients make informed decisions. So basically, not participating in the quality payment program could be bad publicly for many clinicians. So keep those things in mind. You take the hit, but there's other ramifications to keep in mind. So I know we have about 5 minutes left, and I'm going to speed up to this last couple of slides to see if we can get some questions. So here's the timeline. You will notice that the timeline here for 2026 through 2019, Medicare physician payments increased by 0.5% each year, regardless of whether or not you participate in any of the 3 current programs. For January 2019, based on your eligibility, so your reporting on 2017 will determine your your 2019 payment. So based on eligibility, physicians enter the APM path or the MIPS path. 2020 through 2025, Medicare fee-for-service payments remain at the 2019 levels. And for 2026 and beyond, there are 2 separate annual updates. For those that are qualified APMs, they will receive a 0.75% increase. For those that are not qualifying APMs, they will receive a 0.25 increase. Now, while the bill retains Medicare fee-for-service payment model, and participation in the new models is entirely voluntary because you can decide not to take part in all this and take the monetary hit, the legislation highly incentivizes and supports transitioning to this new and significantly different payment and delivery models. Now, I'll fast forward, and I will say that this here, what you're looking at this is how IBM Watson Health Solutions are expected to support MIPS. With its acquisition of Vitel and Explorus, IBM Watson Health does expect to offer several solutions. IBM Watson Health is revisiting our current reliance on EHR vendors to report. And as noted before, IBM Watson Health looks forward in partnering with you as a health IT vendor. So please do keep us in mind if you think and you're curious to know what our products do have in store for you. Please write your name, put it in the question. We'll try to get somebody to be able to get back to you as soon as possible. We are trying to make this as seamless as possible in terms of reporting goes. So please do reach out to us. We'd love to talk to you. Now the takeaways, MACRA changes the way Medicare pays clinicians and offers financial incentives for providing high-value care. Only Medicare Part B clinicians will participate in the MIPS program. And reporting starts January 2017. Payment adjustments and bonuses will begin 2019. And the final rule is targeted November 1st, and we will keep close eye watch on that. Here are my references. And now Sean, I'd like to open up to some questions. I think we have a few minutes.
Great. At this time, you can submit questions using the question panel located near the bottom of the control panel. We will take time to answer as many questions as we can, and we'll let your questions come in through the queue. And Maria, there were a couple questions that I noted throughout the presentation that were asked. So I'll just go down the line.
Okay.
Here's the first one. My practice has 5 physicians, but I'm afraid that the burden of time and cost for technology to report to the MIPS program is too great. Is there an option for our practice like mine to report to CMS?
Fantastic question. So I will say that CMS proposes to reduce the number of required measures in the quality category and the advanced care information category, particularly for those solo practitioners and small practices of, say, 2 to 9 clinicians. I will also say that if a clinician only has data for a portion of their year, because you are a small practice, CMS may allow clinicians to be scored based on that data that they're able to submit, so keep that in mind. I will also mention that specifically for those solo practitioners and those small practices, CMS is actually supporting those individuals through education, training, and they're providing technical assistance. Actually, in fact, CMS is investing, I want to say it's about $100 million over 5 years in technical assistance to help practices improve their performance in MIPS. And basically to help them transition into that APN, as you know, that there's more incentives if you belong to an APN. And basically this assistance will focus on small practices and solo practitioners, but really just in general, if you do have any questions, I do encourage you to reach out to CMS. They're trying to, it's a learning curve for them too, so I will say just reach out to them. They're happy to help.
Maria,
we have time for one. Sorry, go ahead.
I'd like to also add that
yes.
For the practice, consult your state medical society and your specialty society, because there is a lot of help out there with clinical data registries that they may be able to assist you with. As well, talk to your EHR vendor, because several of them have EHR embedded reporting capabilities. So those are 2 relatively low-cost opportunities to get into the technology.
Absolutely. Thank you so much for that information. Yes. And Sean, I think we only have 30 seconds. I don't think we'll be able to take questions, any more questions, and I do apologize that time didn't go over, but I just made it just in time. Do note that please do submit those questions. We will make every effort to answer every single one of those and get back to you as soon as we can. And again, if you're looking for someone, and please do keep IBM Watson Health in consideration. We look forward to speaking to you closely about what we have to offer. Sean?
Great. I would like to thank both Marie and Bill for their time today. As a reminder, you will receive a follow-up email that includes this presentation and a link to the recording within 2 business days. Also, we ask that you take the brief survey when you log off the webinar to help us learn more about what was effective and where we can improve. At this time, the webcast has ended. Thank you for attending and have a wonderful day.